Hey everybody, it's Eric Yazel. I just wanted to go over another subject for a quick mini lecture. All of us are using Tidal CO2 now, and we have a basic familiarity with it, but I thought it's always a good idea to review it a little more in depth and maybe possibly learn some new applications for it that we weren't familiar with. So I'm calling this one Tidal CO2 and you. So what is it? Basically, the formal term is called waveform capnography. But remember, it's both a wave and a number. And I think a lot of times we get focused on the specific number and we don't pay any attention to the shape of the waveform. And we can get a lot of information from that. The number is the amount of CO2 at the end of exhalation. And the normal number is 35 to 45. The other part's called the waveform, and we'll show you a picture of that as well. So what's it tell us? It tells us information about the patient's respiratory status. It can also tell you some information about the patient's pain control and sedation level. It can give you information on CPR efficacy. It can also tell you when there's ROSC, and also some information regarding acidosis as well. So this is a normal waveform, and you get a rise, and then it plateaus off. And think about it, when you're breathing out, it's fast at first, and then you reach a maximum speed, and then it plateaus off. And then when you take your next breath, it goes back down again. So the fast exhalation, the plateau, and then breathing in again. And that point at the end of that plateau phase is where you get your end-tidal number from. And what's it tell you? It tells you some breath-to-breath ventilation data. Remember, capnography measures ventilation versus oxygenation when you're measuring on a pulse ox. Ventilation is the air that moves in and out of the lungs, while oxygenation is the amount of oxygen inhaled by the lungs that actually gets in the bloodstream. So when you're wanting to see, absolute time-dependent breathing, ventilation is what tells you the most. And we've all seen this when we're intubating and we get the tube in and the sats stay down in the 60s for a butt puckering 10 or 15 seconds before they go back up. That's showing oxygenation. While the patient's actually ventilating, they just haven't oxygenated yet. So the more up to speed, real-time measure is your ventilation, which is reflected in your end-tidal CO2. Also shows you respiratory effort. In people with healthy lungs, the brain responds to levels of CO2 in the bloodstream to control ventilation. That's the whole, process behind not wanting to give some COPD patient too much oxygen and knock out their respiratory drive. So shown by chest rise, respiratory rate, and breath sounds. Those are previously some of the things we use to assess a patient's respiratory effort. But now end-tidal CO2 can give us a lot of that same information. The patient's respiratory rate should increase as their end-tidal falls and decrease when it becomes higher in a normal physiologic and mental status state. One of the first things we like to talk about is asthma and COPD. End-tidal can help diagnose, determine the severity, and show the response to treatment for these patients. Decreased air movement causes a buildup of CO2, and it causes the normal box-shaped waveform to look more like a shark fin, and I'll show you a picture of that. In a patient with a history of asthma and COPD that has more rectangular shaped waveform, that would indicate that there's some breathing, increased work of breathing from another source. Say a young asthmatic patient that maybe has a lot of anxiety, if they're using some accessory muscles, a very tachypnic, and then you look at their waveform and it's a normal box like anything else, then you know that there may be some anxiety or hyperventilation component to it, which is obviously very useful. So this is the shark fin that I talk about. And basically what you do is you lose that plateau. And if you think about it, when you listen to an asthmatic's lungs, they get that rapid, exhalation, but they never really reach that plateau because they never fully exhale. They're wheezing and they don't get that maximal plateau. So they get the shark fin kind of appearance. So just always remember that, file that away. You get your loss of plateau, and the shark fin appearance with asthma or COPD. Up in that top right corner, you'll also see that the end-tidal CO2 is often a little higher, greater than 45. And that's another important thing to remember. We'll talk about that later when differentiating from CHF. The more pronounced the shark fin is, and the higher the end-tidal, the more likely respiratory failure is. And, that'll happen well before you see your pulse ox changes. So if your shark fin's becoming more and more pronounced, but they're still holding their sats, you need to prepare for the fact that they are going to decompensate and maybe start considering your, some of your rescue meds and things like that. Conversely, if they have a shark fin and it starts to become more box-shaped, their waveform, and that end tidal improves after albuterol, steroids, whatever else you've done for them, then that's, would be considered a good response to therapy, and you'd either want to continue or continue supportive care. We talked about this a little bit. Hyperventilation is difficult to distinguish from COPD or asthma. You could previously get burnt. If you've got a patient with increased work of breathing but normal SATs, you might say, oh, they're just, anxious and hyperventilating. Well, just remember, anxiety is also a side effect of albuterol. So, it could have a negative effect if you're keep giving duonebs to somebody with anxiety with a box-shaped waveform. Just remember there's a low end tidal CO2 because they're rapidly blowing off CO2. And you can use that number to coach them on slowing their breathing down. So if their end tidal is very low, you can say, slow down, have them breathe in a bag, or, the old non-rebreather at 2 or 3 liters a minute trick for that as well. So don't use this as a hard, fast rule, because you can also get a low end tidal number and an increased respiratory rate in sepsis and DKA and other acidotic conditions. So don't get burnt on this. And this is a waveform you see with hyperventilation, you see, you've got a box shape waveform and gradually lower and lower end tidal CO2s. That can also be a sign of worsening acidosis, but when it's happening in real time, like in a picture like this, it's usually going to be from hyperventilation, to where they're just breathing fast and lowering their end tidal CO2 very rapidly. One thing we don't think about is end tidal CO2 and trauma. And I first started noticing this a few years ago. Anytime we'd be in room 9 with the trauma team, almost one of the first things they do on a severe trauma patient is get an ABG and check for a base excess to guide their resuscitation. This is kind of the same thought process, basically. End tidal depends on adequate ventilation and adequate blood supply to the lungs as well. In the setting of trauma, if internal organs are not being perfused, neither are the lungs. Say you've got a splenic injury and they're becoming hypotensive, there's less blood return to the heart and secondarily to the lungs in this situation. So in a low end tidal in a setting of a traumatic mechanism, you have to have concern for internal injury. And this can be important because almost all severe trauma patients have an elevated heart rate and an elevated respiratory rate. It's hard to tell if it's from a stress response or actually a traumatic injury. Also can be used to monitor your resuscitation. So if their end tidal is improving with fluid resuscitation, or if you're one of the services that gives blood products as well, then you can use that to guide your resuscitation, and also use it to guide your transport decisions. Obviously, around here, most major trauma goes over to U of L, but if you have a patient you're on the fence about that has a low end tidal CO2 in the setting of trauma, that certainly would influence your decision to go to a level 1 trauma center. Again, that's what we're talking about. And you kind of get the same thing, like say a patient with a rapid blood loss in the abdominal cavity that's getting less and less perfusion, they're going to get lower and lower end tidal CO2. So this would be a sign of a patient that's actively becoming unstable in your care. We all know these. We see plenty of overdoses in these days. And the final common pathway for almost all overdoses of at least sedation medicines or pain medicines is respiratory depression and altered mental status. So not only are you going to breathe slower, but you're also not going to have the normal cerebral response to hypoventilation in these situations. And basically, you can use your end tidal to determine the need for assisted respiration and also to monitor for impending respiratory failure. So again, in altered mental status and sedation, you'll actually get almost a hyperventilation picture and then some apnea and then a hypoventilation picture with an elevated end tidal CO2. And I'll show you this picture. You can use these to guide your decisions for Narcan use or just to do tactile stimulation or more invasive airway support. So the top one, just to kind of go where we've talked about a little bit. Top one, there's your shark fin with your asthma, COPD. You lose that plateau, so it's a shark fin. Hypoventilation, big long breaths with high end-tidal CO2s. Hyperventilation, short, more rapid respirations, lower end-tidal CO2s. And then down here in the bottom, this is what you get in a overdose, or even say you have a patient that you gave pain medication to for a long bone fracture or something like that. Say they were, opiate naive and became oversedated. You see a gradually lower end-tidal CO2. And why is that? Because basically they've quit breathing, so you're not getting any end-tidal CO2 out. So then you see this period of apnea, and this whole time, all that CO2 is building up in their lungs because they haven't exhaled. So boom, your next breath has a very high end-tidal CO2. Does that make sense? So lower, low, low, apnea, high end-tidal CO2. This is one of my favorite things for uses for end-tidal CO2 is basically in your full arrest. In the advent of bedside echo in the ER and for end-tidal CO2, once you get to a destination, I really don't see a need for pulse checks anymore. But we'll get to that. One of the things that it shows is your CPR quality. End-tidal, like we said, depends on blood flow to the lungs. Well, a return of blood flow to the lungs is one of the best measurements of quality of CPR. If you're giving good, solid compressions, you should be able to get an end-tidal CO2 of at least 10. If it's low, you need to look at the provider and make sure that they're doing enough depth and that the rate of compressions is appropriate. The other thing to watch for is if a certain provider gets to is a consistent level of 20 and then all of a sudden drops down to 10, you need to see if you've got a fatigued provider or something has changed in their CPR delivery. And this is, we've talked about this. This is one of the most important indicators of a successful resuscitation is, good, high quality, uninterrupted CPR, and your end-tidal CO2 is the best definite measurement of this. Back to where I was talking about the pulse checks. They're inaccurate, they're difficult, with our bigger body habituses. And the longer you spend doing a pulse check, the less time they are in that window where you have enough perfusion pressure to have a successful resuscitation. So basically, if you're watching your end-tidal CO2 monitor and it's consistently at 15, 18, and all of a sudden it rises to 38, you have a pulse. So if you don't have that, then there really isn't a whole lot of reason to check over and over again. And this will show a lot of times in patients even before a pulse is palpable. So, it just shows a return of spontaneous blood flow to the lungs. So on the other side, it's also important because if your end-tidal CO2 has never gotten over 20 after 20 minutes, the statistics are really dismal on the chances of having any kind of neurologically intact survival. And that's a good time to start considering termination. So again, it gives you a hard, fast number to help you determine when you should stop. And so this is kind of what happens in your CPR end-tidal CO2s. The first red line is showing CPR, and basically you get this waveform here that never gets over 10. So they're doing wimpy CPR. So you need to look and see if it's something with the patient's body habitus that can't be helped, or if the provider needs to do more depth with their compressions or more rapid compressions. The second one shows what happens in ROS. So you've got a good CPR here, then you've got a good compression that gets over 10, then all of a sudden it shoots up to 30. That's when you have return of circulation. And like I said, it's time to stop CPR. And, if you're at a facility, plop the ultrasound on to see if they have a good heart squeeze. So again, this is kind of what happens in a longer resuscitation. So you've got CPR, low end-tidals, low end-tidals, low end-tidals. The lightning bolt there means they got shocked, so they didn't respond to the first shock. Though, however, they did have their end-tidal start to improve. And as you can see, they're well up over 10. In fact, they're up to almost 20, which is where you need to be to have a chance of success. So you have a nice long period of end-tidals in the 20s. Boom, another defibrillation. And all of a sudden, your end-tidals go up to 30s or 40s. And again, that's when you have ROSC. So like I said, it's an easy, quick way to avoid having to do pulse checks and make sure that you're doing long, good, uninterrupted CPR. CHF, this is one that's hard to tell. A lot of times it's between COPD and CHF in your undifferentiated breather with poor lung sounds. A lot of pulmonologists would throw a fit with this, But if your end-tidal CO2 is greater than 37, it's unlikely to be CHF. And that's again with the lung dynamics that happens with COPD or asthma. If you progress to cardiac shock, you'll get less pulmonary blood perfusion, and the shape will take more of a tombstone and then a ghost appearance. So let's look at a couple of those too. So first you got kind of your normal box-shaped waveform, and then all of a sudden it becomes more rounded. I call these like the Pac-Man ghosts. So you have a little Pac-Man ghost there, a little Pac-Man ghost there. So let's go back and look at these again. These are, really if you want to get in depth, you can learn a ton of information by measuring out these waveforms and things like that. And I'm not trying to overwhelm you with physiology and stuff like that. I just want to learn the basic shapes and, hopefully help you differentiate between COPD and CHF just with the shapes here, which is really pretty easy. So you've got your normal waveform here, kind of a box shape. There's your good old shark fin for COPD or asthma. And there's your Pac-Man ghost with CHF. Kind of cool. So let's talk about sepsis. From the pre-hospital side of things, you haven't got hit quite as hard as we have in the ER, but we get sepsis to death around the emergency department. And their big thing are these care bundles and early diagnosis, so you can do early goal-directed therapy. Again, like we talked about, end-tidal has both ventilatory and circulatory components, so it depends on oxygen delivery, diffusion, and blood flow back to the lungs. Again, not to beat you to death with physiology, but cells use oxygen and glucose for energy and release carbon dioxide back into the bloodstream to be carried to the lungs. And in sepsis, there's inadequate delivery of oxygen to tissue, leading to an acidosis, so essentially more CO2 is brought back into the lungs, and then the body increases ventilation to compensate. So you'll actually see a low end-tidal CO2. And so basically, it's kind of a cool way to diagnose sepsis early. Your main marker is for lactic acid. So the higher the lactic acid, the lower the end-tidal. And the big thing in our ER literature is any lactic over 4 is kind of a marker for increased mortality and higher severity of sepsis. So if you have your 2 SIRS criteria, I don't know if you're familiar with SIRS, but basically if they're febrile or have an elevated respiratory rate or low blood pressure and an end-tidal less than 25, that correlates strongly with a lactic greater than 4. And so you could consider administrating, pre-hospital IV fluid bolus for sepsis, and there's some services that are even dosing antibiotics. So this is kind of cool. Like say you have, an undifferentiated fever from an extended care facility. You don't know if it's pneumonia or UTI or anything, but they have a fever of 103 and, blood pressure is 90. You don't know if that's what their baseline blood pressure is, but all of a sudden if you put that end-tidal on them and they have those 2 SIRS criteria and say their end-tidal is 22, then this patient's septic. And that helps you to prioritize your triage once you get to the hospital and things like that. So, and like I said, helps guide your fluid resuscitation. Hyperglycemia, this is another cool one. There's one guy that advocates for this that says your end-tidal CO2 is really your breathalyzer for DKA. And one kind of cool stat, basically, if your AccuCheck's over 500 and your end-tidal is greater than 35, 100% they're not in DKA. If your end-tidal is less than 21, it's 100% that it is DKA. And if your end-tidal is less than 26, it's 90% that it's DKA. And this is one of my pet peeves is a lot of people, anybody who has an elevated blood sugar, everybody say, oh, this patient's in DKA. Well, a lot of people walk around our area with blood sugars in the 500s and 600s on a daily basis. And by no means are they in DKA, and they're not even, acutely ill. So right there, you can pop this on to decide if somebody's, is in DKA and has potential electrolyte abnormalities and may have, CNS dysfunction versus somebody who's just at their baseline elevated blood sugar. So just remember, end-tidal greater than 35, AccuCheck more than 500, not in DKA. End-tidal less than 21 and a blood sugar greater than 500, definitely in DKA. End-tidal less than 26, sugar greater than 500, still probably in DKA. So let's look at them again. So you got your normal waveform, kind of the Exhalation, rapid rise, your plateau, and then inhalation. Next, you got your shark fin. So you got an obstruction, you never plateau off. So this is your COPD and asthma right there. This one here is kind of interesting. Like say you're taking a patient who's been paralyzed for intubation and put on the vent. As they start to wake up sometimes, you'll see this little dip in their plateau. That's a sign that they're starting to wake up from their sedation. Over here is a CPR one. So you've got, normal box-shaped waveforms, but down there around 10 because they're not getting, all the perfusion that they need. Hypoventilation, you've got a long, wide waveform with a number greater than 45. Hyperventilation, more rapid, narrow waveforms that are lower than 45. And then say you've got a sick patient, nice looking waveform, and then boom, all of a sudden you lose it. First and foremost, you need to check your equipment to make sure everything's plugged in. But if everything is, then you're in a world of hurt because they just lost their pulse. So again, last time, shark fin, asthma, COPD, hypoventilation, long and wide, hyperventilation, short and fast. This is your sedation. Like I said, you're gradually losing your end tidal to apneic, to where they haven't breathed at all, so they have a huge amount of CO2. And then don't forget your Pac-Man ghost when it comes to CHF. So kind of a check down process. First thing I look for is their end tidal low or high, and that already helps you with your differential diagnosis. Then you want to compare it with a clinical condition. What kind of medical conditions do they have? Does their work of breathing match their end tidal result? Look at the shape. What does it tell you? Like I said, is it a shark fin? Is it a Pac-Man ghost? And then monitor for changes in the shape and number as a response to your treatment. So use those improvements or worsening to guide your therapeutic interventions. Any questions on that? Like I said, I tried to keep it pretty simple, not overwhelm you with physiology, but I hope that's useful. Again, I'm new at this, so please, any feedback, feel free to send it my way. Ask questions, whatever you need, make fun of me, whatever you like. So hope this is useful, and you guys have a good day.